There's a list of 271 quality categories. It's called quality measures. There's a list of 271 quality measures. If you want to fully participate in the quality category and max out your score in the quality category, you need to choose 6. We narrow down that list of 271 to a much, much, much shorter, more manageable list for you. So you don't have to choose from 271. We're going to give you 10 to 15 for you to choose from. They're on the slides. They're in your packet. If you want to fully participate. So what do we mean by fully participate? This was the flexibility that they gave us, right? You're drawing points from different parts of the program. I'm trying to calculate half of 75 in my head, and I'm having a hard time for some reason. 37 and a half. Okay, so let's say you are 15 or fewer, and the quality category counts for 75% for you, because you're 15 or fewer. It's 75% of 100. So if you're perfect in the quality category, if that's all you do, and you're perfect in the quality category, you have 75 MIPS points. 75% of 100. What was the threshold for exceptional performer? 7. So that's an option. But let's say you're not perfect and you don't max the quality category by doing 6, and instead you only do 3. If you are perfect on 3 quality measures, you now have achieved half of the max quality category score. So you would get half of 75, and you would have 37.5 MIPS points. So that's what they meant by they gave us flexibility. You can choose to do all of quality only. You can choose to do half of quality. You can choose to do 2 quality measures. You can choose to not do quality at all and only do clinical practice improvement. So that's what we mean by if you want to max out the quality category. If you want the highest possible score from the quality category, which is 50 or 75, depending on the size of your group, you need 6 out of the 271 quality measures. One of the 6 needs to be an outcome measure. So there's 271 measures. Some of them are outcome measures. Of your 6, 1 has to be an outcome measure. If you choose 3, one of them needs to be an outcome measure if you want to max out those 3. And your measures, whether you choose 2 or 4 or 5 or 6, your measures all need to be capable of being reported by the same mechanism. They all have to be able to be reported to CMS, meaning how you tell them you did it, by the same mechanism. There's different mechanisms. There's different ways you can report this stuff. And we'll show you what we mean by that. These are the mechanisms, the means by which you can report the performance of your quality measures. You can do it via claims, by putting codes on your claim form. You can do it via registry, where you use something else to collect your information for you and submit for you. You can do it via EHR, or there's another option for those that are in a group of 25 or more. Most of us, if not all of us in the room, are going to be choosing between claims and registry. There are advantages and disadvantages to both of those. Dr. Christina is going to touch on that when he talks about registry reporting and the APMA registry. And there are many advantages to that and reasons why you should be engaged with the APMA registry. Both selfish reasons, why it helps you, because it's easier, and bigger reasons to how it can actually help the profession and help podiatry. But still, there are advantages and disadvantages to claims versus registry. We can talk about that. If you are going to participate in the quality category and you want to fully participate, again, you have to choose 6 measures. When you look at these measures, I said there's 271, and we're going to give you a shorter list. Every time you look at a measure, when you read the description of the measure, it will tell you how it can be reported. What is this measure's reporting mechanism options or option? So every measure you look at, you get a description of the measure, and then it says this one can be reported via claims or maybe it says, this one can be reported via claims or registry. Or maybe it says registry only. Every measure has its own thing. Which mechanisms it can be reported by. Some are only claims, some are only registry, some are either or. So you have to decide, what is my reporting mechanism going to be? How am I going to report this? Do I want to do claims or do I want to do registry? Dr. Christine is going to help with that discussion when it's his turn. Once you make that decision on how you want to report, now you go shopping for your measures. And if you've decided on claims reporting, you need 6 that can all go in via claims. If you want registry and you're going to do 6, you need 6 measures that can all be reported via registry because they all need to be capable of being reported by the same mechanism. If you want to max out this category, you need to report on 60% or more of your patients that qualify for your measures. And we'll get into what we mean by qualify. If you want to get a max score, you have to report on 60% or more of your patients that qualify for your categories. Last year it was 50. This year it's 60. The good news about this 60% business is, as we stand here on February 24, if you haven't done anything yet, it's not too late, right? Because we have way more than 60% of the year left. So you could start this on Monday, you could start this on March 2, and you still have the ability to get a perfect quality score. Because over the course of the year, you only need to report on 60% or more of your people that qualify for your measures. Here is where the one exception that we mentioned comes into play as far as reporting on all of your patients. Clinical practice improvement activities, every patient no matter what. Advancing care information, the EHR one, all of your patients no matter what. Quality, if you're reporting via registry, all of your patients regardless of their insurance. If you report via claims, by putting the code on your claim form, it's Medicare people only. Only Medicare people, if you're reporting via claims, if you're reporting your quality measures via claims. There's 271. We narrowed it down for you. I'm going to show you how to view the list. If you don't want to, don't do it. Skip it. You could just go from our list. I think there's some usefulness to going through this exercise, to seeing where they come from. If you want to look through and shop the measures on your own, this is how to do it. Again, we narrowed it down. You don't have to do this nonsense if you don't want to, but we're going to show you how in case you want to. This is the QPP website. Everybody in the room knows what QPP is, right? And because there are 2 ways by which you can participate in the quality payment program, we have MIPS and APMs, right? That's what we talked about. We are MIPS. That's what we care about, right? So if you want to look at these measures, you go to qpp.cms.gov. That's their website. It is, in my opinion, a very surprisingly user-friendly, good website. They got something right. This is totally different from every other Medicare website that exists. This is pretty well done and pretty easy to navigate. qpp.cms.gov. We're looking for quality measures right now. So you click on MIPS, because that's where we live. When you click on MIPS, it opens up this drop-down menu. You can see that one of the options is Explore Measures. We're looking for quality measures. Under Explore Measures are our 3 categories, where there are measures: quality, advancing care information, clinical practice improvement. We care about quality. You click on quality and you get this list of 271 measures that are in alphabetical order. That's all you got, is their names in alphabetical order. And if you want to go through and do this, again, we did it for you, but if you want to, you go through this list, you look for ones that may be of interest to you. When you see one that's a winner, or potentially a winner, you click Add. When you click Add, it starts to populate this column to the side. So you go through, I saw acute otitis externa. I didn't click on that one. I didn't think that was a good one for us. I saw blood pressure management. I did click on that one. So that's what it looks like, right? So you go through the whole list, you fill up the column on the side, and when you're done, you have this list. So I ended up with 42. When you're done, you click that blue download button, and it will download onto your desktop the measures, their numbers, their descriptions, and then there's somewhere else you can go to get even more detail, but we're going to skip that for our purposes, again, because we already did it for you. You need 6. One of the 6 needs to be an outcome measure. All 6 need to be reported by the same mechanism, one of these mechanisms. I said we narrowed it down for you. If you choose to report via claims, these are 10 measures that we thought would be appropriate for podiatrists that can all be reported via claims. There's one outcome measure on there. It says you need an outcome measure unless there are no outcome measures that are applicable to the care that you provide. So we're going to give you 2 different takes on this, and then you decide what you're comfortable with. The only outcome measure that I could find at a 271, let me rephrase that. The only outcome measure I could find that could be reported via claims is this hemoglobin A1C measure, where we have to get the lab value and report on their A1C, whether it was under 7 or over 7. And that's an outcome measure. And I think that is applicable to our care enough that it would be difficult to make the argument if you didn't do this and you were audited that you might have a hard time saying, well, there weren't any. If they come and say, you didn't do an outcome measure, you say, well, that's okay because there weren't any that were applicable to my care. I'm worried about them saying, yes, there was, you could have done that one. But an even bigger reason for me is I don't want to have to worry about it. I just want one in there. And then nobody can come say, I didn't do an outcome measure. Dr. Christina doesn't totally agree with that, so let's give him a chance to voice his side.
So there's a couple problems with the hemoglobin A1C. First of all, we do not prescribe medications to control patients' diabetes. That's up to their primary care or their endocrinologist. So the fact that we don't do that, I don't think that's within our scope of practice technically. So I think you're fine. So I don't think you need to have I don't think you need to do that outcome measure. Now what it says is if there's not an outcome measure applicable, then you need to have at least one high priority measure. And there's several high priority measures on there. Falls prevention is one of those. The other thing about the hemoglobin A1C is since you don't control that patient and you have to report on at least 60% of your eligible patients, if that patient is out of control, that's going to give you a poor performance on that measure. It's going to affect your overall score. So why should you have to use a measure that you have no control over and can decrease the score that you might achieve? I don't think if you got audited, you'd have any problem. I don't think they expect you to actually treat the patient's diabetes. You're treating the systemic manifestations of diabetes in the lower extremity. So my opinion is, don't do A1C, do a high priority measure, and you'll be fine. But as Jeff said, you can, if you feel like you just don't want to take the risk, but I don't think you'd have any problems in an audit defending it. I think the odds of being audited for that are very, very low.
And I agree with the odds being very low deal. Thanks, Dr. Christina. So those are 10 claims eligible measures. Doctor.
I have a question. How is your office set up to get that information?
Okay, this is great. Doctor asked, how is the office set up to get that information? I'm going to answer that in about 3 slides. Important question, right? With nuts and bolts. How do I do this? I promised we were going to tackle that. So we'll get there. We're going to give you that. Those were 10 claims eligible measures. We pulled out 15 registry eligible measures. So if you choose to report via registry, the list you have in front of you is 15. There's one outcome measure on that list. And then the same conversation applies. There are some, now Dr. Christina is going to talk to you about the difference between just a registry and a QCDR, a Qualified Clinical Data Registry, which the APMA registry is, which is kind of a big deal. There are some registry measures that are only QCDR measures that are not on this list. Dr. Christina is going to get into that further. For our purposes, if just using a registry, these are your 15 measures from which you can, I suggest that you pull out 6. There is an outcome measure on there if you choose to go that route. If you are using a QCDR, which the APMA registry is, you have more options, which Dr. Christina is going to share with you. Now I'm going to get to Doctor's question. Once you've picked out your 6 measures, now you must intimately know your measures. 2, 3, however many you pick. If you pick out 6 measures, now you must know your measures inside out and backwards and know everything about your measures and how to report it. Like Doctor said, how to set up your office. How do you actually make this work to report the measure? So to model that, we'll pick one and we'll dissect a measure to show you what I mean by know it intimately and how to track this craziness. So I picked to model tobacco screening and cessation intervention. I thought that was one a lot of us might do. It's one I'm doing. I think it's an easy one. I picked this one. Tobacco screening, cessation intervention. Now you have to know your measures. And the first thing you need to know about all of your measures is the denominator. The denominator tells you, who do I perform this measure on? Who among all my patients do I have to ask if they use tobacco or not? That's what the denominator answers. Who goes into the denominator? Who do I have to ask about tobacco use? Who do I have to ask about their hemoglobin A1C? Blood pressure, right? Whichever ones you choose. Each measure has its own denominator. Some of them are different. You might have one measure with one denominator and a different measure with a totally different denominator. The denominator for this measure is over 18 and has one of those codes on their claim form. Don't be intimidated by that list, because all it is E&Ms. It's the evaluation and management codes that we know very well. 9920s, 9921s, we all know those, right? Those are E&M codes. Over 18 had an E&M. Now, if you're reporting via registry, the denominator for this one is over 18 and had an E&M. If you're reporting via claims, the denominator for this one is over 18, had an E&M, and Medicare. Somebody got it, right? Because if you're reporting via claims, you only do it on Medicare people. If you're reporting via claims, if the patient in the chair has private insurance, doesn't matter. You don't have to do it on them. That's your denominator for this measure. Over 18, had an E&M. If they don't meet the denominator, you don't have to perform the measure on that patient. If they come in and they get a 11721 and leave with no E&M, they didn't fall into the denominator for this. You don't have to report it on them. They don't go into the denominator. They don't count for you or against you in any way. And I'm making that point because we often get asked, well, now I have to start making up E&Ms if there wasn't one really there just to qualify them? No, don't ever do that. If an E&M didn't happen, they don't qualify, and that's fine. And that doesn't count in any way. They don't go in to your denominator. So that's the denominator. Now, if you identify this patient meets my measure denominator, now you have to perform that measure upon that patient, which for this one is to say, do you use tobacco? The hemoglobin A1C one will be to get their most recent A1C value. You ask them if they use tobacco. Now, each of the measures also has a numerator. Reporting options with codes. Now I did it. Now I'm going to tell them that I did it. These are the numerators for this tobacco screening and cessation intervention measure. So let's look at the second one first, because it's really easy. They're a non-tobacco user. Do you use tobacco? They said no. Well, there's a code there, 1036F. So now you identified that they met the denominator. You asked them if they use tobacco. They said no. You have to document Patient was screened for tobacco use and found to be a non-tobacco user. And then if you are reporting via claims, you have to put that code on your claim form. 1036F. Whatever diagnosis is pointing to the E&M, because there was an E&M if you did this, that same diagnosis points to the quality measure code, or codes, if you're doing multiple, if this patient qualifies for multiple. So whatever diagnosis, tinea pedis, right, B35.3, you could have that pointed to 99202, and that same diagnosis also pointing to 1036F, if they're a non-user. And of course, you have to document it. Now let's look at the top one. This is just one measure now, right? 1 out of 6. This is what I meant by know your measures intimately. Patient said they do use tobacco. Well, this measure calls for, if they are identified as a tobacco user, providing cessation intervention, which for this measure does not require writing a prescription, only requires providing cessation counseling. You provide them with counseling on their tobacco use, and you document that you provided counseling about their tobacco use. Whatever you do, right? I'm going to make this up. You can steal it if you want. This is kind of my template, just going by memory. Patient was identified as a tobacco user. We discussed their tobacco use. I explained that that can have a negative impact on lower extremity health and cardiovascular disease, and they should discuss options that exist to help them quit with their doctor. Something, right? You've provided cessation counseling. That's all you need to do. If you do that, you have to document it with something like I just spit out, and then code it. Now there's a different code, 4004F, for that one. The third one is if the situation is so dire and emergent, you don't have the opportunity to do it. I think that's rare and never the case for us. And the last one is they were identified as a tobacco user, and I didn't do anything about it, which is weird. It's an option. You'll get some points, but not as many as you could as if you actually perform the measure. So now let's answer Doctor's question. How do you do this, right? The most efficient way to do this is if you have an excellent electronic health record, where instead of doing what I just said, where you or your staff has to know your measures intimately, it knows your measures intimately. And you tell it what your 6 measures are. And it knows by the intake that was performed at the front desk, their age, whether they have diabetes or not, whatever other things that might fall into the denominators, right? It has all the intake information. It has past medical history. It knows who's in the chair. It knows by you punching it in or by the template that you choose if an E&M was performed. And it tells you what measures to perform, and you don't have to think about this craziness. Because if you're not doing that, now if your 6 measures are about, they have to be over 18, E&M, this one they have to have had diabetes, this one they have to have had a fall in the last 2 years. Now for every single patient, you're checking all 6 of your measures. Okay, the first one is over 18. All right, they're over 18, I'm going to do it. The next one is a diabetes thing, which is between 18 and 75 and they have diabetes. Now you got to figure that out. And you have to go through all your measures. So the best way and the most efficient way is to have an EHR, which allows you to tell it what your measures are, and then it prompts you. And then more efficiency, for example, would be it knows the patient's over 18 and had an E&M, you get a pop-up. Ask them if they use tobacco, doctor. Do you use tobacco? They say no, and you click one button, no. And it populates your note with the template, patient was screened for tobacco use and found to be a non-user, and it puts the claim on the claim form. Or if you're using Registry, it sends that information to the registry for you. That's efficiency. If you don't have that in place, now you have to have a checkbox system, which I would suggest should be done by staff, not the doctor, because now this gets to be crazy. And now somebody, maybe the person who's rooming them, MA, whatever, knows what your 6 measures are, And now they start crossing them off for every single patient. Are they over 18? And then it depends on what your measures are. And again, different measures have different denominators. So you might have one patient that qualifies for all 6 of your measures, and you do all of them. You might have another patient that only qualifies for 2. So we'll do an example on that. This one's 18 or over, had an E&M. The diabetes ones, like diabetic foot exam, is between 18 and 75, has diabetes, and had an E&M. So if you see an 80-year-old patient, that patient qualifies for the tobacco one. They don't qualify for the diabetes one. You would only do the one of the 2. If you see another patient that's 50 and has diabetes, now you have to do both on them. So you'll have different denominators, if you're still with me on this. I think we're getting a little bit into the weeds now, but important for those that are still following, that you'll have different denominators for each of them because different people qualify for your different measures. So it depends on your practice. Efficiency is using an EHR to help you, or you have some sort of checklist in place where the person that walks in the room knows what the measures are, knows which questions to ask. Then you have to document your performance and code the performance or be aligned with a registry where you can click the box that you did it.
Going back to that A1C.
Yeah.
So you go to, you call, have the staff call the doctor, send over
Yeah.
the number.
Yeah, okay, so doctor asks for the A1C. Do you need the lab value? You do. You are not supposed to go by what the patient tells you. You're supposed to get the lab value. Are you going to tell me I told you something different last year? No. Oh, good. Because I may have.
It says recent lab value. Does that have like a 3-month?
Correct. So question was, it says recent hemoglobin A1C. Is there a statute of limitations on that? I am not aware. Anybody going to correct me? No? I am not aware of a timeline on that. We get to judge that. A year feels good to me. I'm totally making that up. That's based on nothing. I have no source to support that. Just feels right. I would ask them, have you had an A1C in the last year? I'm not aware of a timeline that they give us on that. Dr. Christina.
Just the A1C, you need the documentation on. Smoking cessation, you can take the patient's word for it. They can come in with a pack of cigarettes in their pocket and smell tobacco. If they tell you no, you can put no in there. That's patient reported versus having to have the documentation.
So I'll repeat that for those on video. Dr. Christina shared, for A1C, you have to have the lab value documented from the lab. Tobacco, that you can just do on your own. And that goes back to what Dr. Christina said about if you want to score high and have a better score, you want to pick measures that you can have an impact on, which is another reason to thank and support APMA, because they developed measures like the diabetic foot exam measure that we can actually impact. So we have our own measures. Any questions on quality? Dr. Tower.
Where do you actually go to get those codes and measure specifications?
So I don't have a screenshot. All right, the question was, where do you go to get the specifications? If you are an APMA member, it's all done for you very cleanly and neatly. If you want to write this down, this is not in your packet. If you go to apma.org /MIPS 2018, MIPS 2018, apma.org /MIPS 2018. So we just showed you the specifications. What do we mean by specifications? We just showed you the specifications for 1. If you're going to choose 6, you need denominator, numerator, who qualifies, codes for all 6. We only gave you 1 because no sense going through all of them. I think you get the idea. On that website, apma.org /MIPS 2018, you'll see quality measures and then a claims list and a registry list, and you get the PDFs with all of those for all the measures that we gave on those lists, with the 10 for claims, the 15 for registry. Event, yes, please.
Oh, you can finish your thought.
No.
I just said, this will have to be report, like, so a patient comes in January.
Yes.
6 months later,
Oh,
you have to do it once.
I'm so glad you asked that. The question was, what if you see the person multiple times? Do you have to do it once or do you have to do it every time? It depends on the measure. So now we go back to measure specifications. Every single one of them, and they actually make it really clear and easy, believe it or not, every measure in bold, in the first sentence of every descriptions measure, it says, once during the reporting period, or it says, for every encounter during the reporting period. They actually did it in English and made it really easy to understand. So if it says once per reporting period, if you see them and they qualify 15 times, you only have to do it once. And it doesn't matter if it's the 5th time or the 7th time. If it says for each encounter during the reporting period, then you have to do it every time you see them that they qualify during the reporting period. Did you want to add something? Gail?
Yeah, it would also just be really certain you're reading the measure specification for the correct method of reporting that you're utilizing. Because I remember last year with is it the smoking cessation one?
Yeah.
For the claims reporting, you only needed to report on it once for the patient. But
Right.
if you're reporting via registry, you needed to report on it at least twice.
Right.
So you need to make sure you're looking at the correct specification
Right.
for the method you're reporting by.
So Gail Reese, APMA Health Policy and Practice Department, thank you for pointing this out. Know your measures intimately. So the point Gail made, which is crazy, is that when you look at the PDF for the tobacco measure reported via claims, the specifications, it's different for the specifications for the tobacco measure reported via registry. And the one for claims says once during the reporting period, and the same measure reported via registry says you have to do it twice during the reporting period. So know your measures, the descriptions, the PDFs are on that website.
And similar to it being in bold, how many times you might have to report on it, at the very top of the measure, it'll say this is for registry only or this is for claims only. So it'll be very clear when you're looking at the specification and the title, which one it's for.
So Gail pointed out when you download that PDF, when you look at the specification, it will very clearly say that measure via claims or that measure via registry. It's easy if you go through the APMA site using your membership because they're listed by either claims or registry. Makes it easy.